We are live.
Hello, good morning, everyone. On behalf of AIOS, I welcome you all to the 7th episode of the AIOS Guru Sangam program 24-25 edition. This is the 7th episode of the Guru Sangam program this year, and today we'll be having some great cornea conversations. Well, the Guru Sangam program was initiated last year, and the reason, the author behind this program is to educate the postgraduates in our country, to elevate the standards of education, and to help our young ophthalmologists to excel. So, Guru Sangam is a series of over 80 lectures over the next 2.5 months, where we invite distinguished teachers to present on subjects of their choice. So, they do an in depth coverage of the selected topic. And at the end of this program, we'll be inviting all the teachers to New Delhi, where we have the Guru Sangam Conclave. So, this Guru Sangam Conclave is a great learning for our young ophthalmologists and also the budding teachers in our country. With that, I very warmly welcome you all to this episode of Guru Sangam. I'm Dr. Tinku Bali, and I'll be your moderator for this for this episode. Before we begin, I'd like to thank the chairman of the Guru Sangam program, Dr. Samar Kumar Basak, who's also the president of AIOS, for his constant encouragement through this program. I also thank the program directors, Dr. Santosh Munawar, the secretary of AIOS, and Dr. Manoj Mathur, the treasurer of AIOS, who have so meticulously designed this program and fine-tuned every tiny detail. I very warmly welcome our expert panel who's with us this morning. Thank you all for sparing time on a Sunday to be with us. And I'd like to introduce you to the panelists who will be giving their inputs at the end of the talks. We have with us Dr. Alok Sati, a very distinguished and eminent ophthalmologist from the Armed Forces Medical Services. We have Dr. Josephine Christie, who is the Chief of the Cornea and Refractive Surgery Services at the Arvind Eye Hospital, Pondicherry. Dr. Rama Rajagopal, who's the Director of the Cornea and Refractive Surgery Services at the Shankar Nethralaya, Chennai. And Dr. Revati Rajaraman, who is the Chief of the Cornea and Refractive Surgery Services at the Arvind Eye Hospital, Coimbatore. A very, very warm welcome to you all, and thank you so much for your presence here this morning. So with that, I also welcome all our speakers, our 3 speakers who are with us, and also the audience that have logged in this morning. And before we begin our first talk, I'd give you an introduction to our first speaker, who is Dr. Devi Aishwarya Das. Dr. Devi Aishwarya Das is currently working as a consultant in the Cornea, Cataract and Refractive Services at the Dr. Agarwal's Eye Hospital, Cuttack. She completed a fellowship in general ophthalmology from the Shankara Nethralaya, Chennai, and then a short-term cornea fellowship from the L.V. Prasad Eye Institute, Hyderabad. She has over 24 years of experience in clinical ophthalmology and over 15 years experience as a DNB teacher. She was also earlier the DNB coordinator in her institute. She has made several presentations both at the state and the national level, has been a thesis guide to several of her students, and has several publications, including book chapters, to her credit. So with that vast academic experience, Dr. Devi Aishwarya Das, I'm sure, is going to give us a great overview of her subject of choice, that is managing corneal perforations. So welcome, Dr. Devi Aishwarya, and over to you for your talk.
Good morning, everyone. Thank you, Dr. Tinku, for that introduction. And thank you, AIOS, for this opportunity. So I'll be starting with my presentation. Is it visible?
Yes, it's visible.
Is it full screen? I'm not sure.
It's not full screen right now.
Is it full screen now?
Yes.
Yeah. Good morning, everyone. So I'll be taking you through managing corneal perforations. When we come to corneal perforations, it's a potentially devastating complication. It causes may be varied, starting from traumatic, from non-traumatic. Non-traumatic could be infectious or non-infectious, like in cases of keratoconjunctivitis sicca, neurotrophic keratitis, or collagen vascular disorders. Now, before we come to manage any disease, likewise in a corneal perforation, we must be sure that there's a perforation. So how does one go about identifying a corneal perforation? We have some classical signs. That is, we have a visible perforation site with shallowing and a flattening of the anterior chamber. Aqueous leakage may or may not be seen. Other signs of a corneal perforations, sometimes this perforation could be doubtful. So we must look for leakage of aqueous. For this, we can do a Seidels test or a force Seidels test. But a caution here, before we try for a force Seidels test, we must be sure that we have the mechanism and the means to address a perforation if it happens on table while trying the force Seidels test. Sometimes we have iris pigmentation in the wound. The iris is a very strange tissue that it tends to go towards the site of perforation, but it also has a tendency to bounce back. Sometimes the AC might be well formed, the iris and the pupil might all be in its place, but we do have traces of a prior full thickness perforation by seeing some trace of this iris pigment entrapped in the wound. Sometimes we might have a spot of infection or some infiltrates. Again, the wound might be sealed after full thickness penetration has occurred, and then it would have got auto sealed on the surface, but there is evidence that there had been a perforation before or existing perforation which might be covered by the speck of infiltrate. Now, how to go about a Seidels test? We can either instill sterile fluorescein directly into the cul-de-sac, or else we can touch a sterile fluorescein strip directly onto the area of the suspected leak after applying a drop of paraffin into the cul-de-sac. Then it is observed under the cobalt blue filter on the slit lamp. A leak will appear as a continuous dilution and an outflow of fluorescein like a cascade. Hence, it's also known as the waterfall sign. So here it is a video demonstration of how we can do a Seidels test. Here I'm touching the fluorescent strip directly onto the area of perforation. Here we can see that beautiful water cascade, and this is diagnostic that there is a leaking wound over there, and it needs urgent attention. Now, what are the management goals when we are coming to deal with corneal perforations? We have to first restore the globe integrity. We have to prevent the complications like endophthalmitis, choroidal hemorrhage, and its sequelae. Then we also must address the underlying etiology in the non-traumatic cases. Now, coming to the medical management of non-traumatic cases, most traumatic cases would need an urgent addressal. Mostly there would be surgical means. When I'm talking about medical management, I'm talking mainly of the non-traumatic cases. Here we have to give supportive therapy to the underlying etiology like autoimmune therapy or infection management, then ocular surface management, promoting corneal healing, and a keen and careful observation before we can decide whether we can continue with the medical management or we need to intervene surgically. Now, coming to the surgical management options, we have many. We have the tissue adhesives, the conjunctival flap, multi-layered amniotic membrane transplantation, Tenon's patch graft, and corneal patch graft, tectonic keratoplasty. I will go through each one of them now. The surgical management of a corneal perforation will depend on various factors like the size, whether it's micro, less than a 3 millimeter or 3 to 5 mm, or more than that, which we would call a large perforation. Then the shape, whether it is circular or stellate, mostly this is to deal with the traumatic perforations. And in perforations with non-traumatic cases, whether the surface of the perforation is concave or convex, the location of the perforation with its central, mid-peripheral or a peripheral one, then the cause of perforation again, whether it's traumatic, non-traumatic, and we must also look whether there's any surrounding tissue loss. So this will again affect the modality of management. Now coming to the first modality, that is the tissue adhesives. They could be non-biologic or biologic. And non-biological ones are the ones that are commercially available, like cyanoacrylate glues. And the biologic, of course, is the fibrin glue, which is commercially available and has to be reconstituted. Or sometimes we can fall back on the patient's own blood serum and on table and take it as fibrin glue in the absence of any commercial available glue. Then it is best suited to manage perforations less than 3 millimeter in diameter, and mostly for perforations located away from the limbus, because there's a poor adhesion between the glue and the conjunctival tissue. Cyanoacrylate polymerizes upon contact with water, thus hardening it and thus seals the perforation. The fibrin glue forms a hemostatic plug upon reaction between its fibrinogen and thrombin component. This is completely biodegradable, and this hemostatic plug will act as a sealant. This is effective for perforation slightly smaller than that cyanoacrylate glue could address. Cyanoacrylate glue is superior than fibrin glue for perforation between 2 to 3 millimeter, because fibrin glue degrades faster. The application technique for cyanoacrylate glue, I'm sorry, I don't have a video here. So we must be sure that the surface is dry and de-epithelialized, because we cannot apply this glue on a intact epithelium. So we must be sure that we de-epithelialize the surrounding tissue of the perforation, and we make the surface dry. We wipe it dry so that we can apply the glue. This glue could be applied at the tip of 27G or a 30G cannula on a syringe, dry, or else we could also use the back end of the Vexel sponge and then apply the glue gently and in very fine layers. Then we wait for the glue to harden and form a seal, and we must make sure that this is covered by a bandage contact lens, because the surface of this applied glue will be extremely rough and irritant to the ocular surface. Now, this is the pre and post images of cyanoacrylate glue. This is before the perforation. Here we see that it is quite a smaller perforation, and we have applied glue, and post glue application, we have intact globe and of course opacification. Here we are lucky that it is central, so there's not too much of vascularization. The complications of the tissue adhesives are, once if there is any contact between the intraocular structures and this glue, we could have stromal and endothelial toxicity, lenticular toxicity, raised IOP inflammation, and of course we can have intense vascularization with cyanoacrylate glue. A word of caution here: whenever we are using glue, we must make sure that it is not in touch with the iris. So if there is an iris picking at the perforation, we must take it up in the OT, and then we must make sure that the iris falls back before we apply the glue. Fibrin glue will degrade more quickly than cyanoacrylate glue and does not have the antibacterial properties. Now coming next to the conjunctival flaps. The traditional superior fornical conjunctival advancement flaps were commonly used. Here we can have a Gunderson's flap where it is taken in toto, or else a CS racket flap where we have a thinner pedicle and it's like a racket. These are used for indolent non-healing corneal ulcers and impending perforations, but they're not very suitable for central perforations because that would need extensive conjunctival dissection. So the disadvantages are we would need a much more extensive dissection of the conjunctiva so that it can be advanced to cover the area of perforation, and it obscures the cornea postoperatively. So sometimes we may not have a view of the underlying pathology. Then extensive vascularization will facilitate healing. This is good in a way. However, flap perforation or fenestration is known, especially when we have stretches enough to advance it too centrally. Flap displacement can occur, and inadequate coverage in large central perforations, of course, is known. Now, coming to the amniotic membrane transplantation, it is usually used in a multi-layered fashion, especially when we are covering perforations or perforations. So what are the properties of amniotic membrane that make it amenable to such treatment? It is rich in growth factors, cytokines and structural proteins. It has antibacterial, anti-inflammatory, anti-angiogenic and anti-fibrotic action. The epithelium contains trophic factors, so they can differentiate and migrate and release proteases that induce apoptosis of the local inflammatory cells. They reduce risk of corneal melt. So they are ideal for cases where we have adjacent adjacent areas of collagenolisis and corneal melting. This can be combined with fibrin glue. They help in managing defects up to 3 millimeter because they do not have a very high tectonic strength. The indications are small non-traumatic perforations with loss of stroma, decimatoseals, stromal melt with the impending perforations. They're better suited to central perforations as compared to the conjunctival flaps. So wherever we see areas of tissue loss or stromal melt, amniotic membrane is a good choice. So what are the limitations of amniotic membrane transplantation? So the success rate will depend on the size of the perforation. For microperforations, it works nearly 100%. And for smaller perforations for up to 1.5 millimeter, it's almost 75% success rate. However, when we have perforations larger than 1.5 millimeter in size, the success rate is only about 40%. Practical issues in usage while manipulating the multiple slippery layers. It's already a very sticky and slippery membrane. So whenever we have to make multi-layers of it, then it's slightly tricky. Then the tectonic instability of the sheets in large perforated areas. They're not very tectonically strong. Now coming to the Tenon's patch graft. So these are some of my pictures. Now, what are the properties of the Tenon's tissue that again make it a good choice? So they're thick, fibrous, rich in smooth muscle layers and fibroblasts. They produce autologous fibroblasts and connective tissue. They can provide structural support, reduce inflammation, as well as accelerate wound healing. So they are good for perforations up to 5 to 6 millimeter in diameter. They're autologous, so there is no chance of immune tissue rejection. They produce autologous fibroblasts, so thus get incorporated in the host corneal tissue. And we do not have to rely on donor tissue. So in the absence of any available corneal tissue or even HOTA in some organizations, we can fall back on the Tenon's patch graft for perforations as large as up to 5 millimeter. So going back to my previous slide, here we can see how it has integrated so nicely into the host corneal tissue. Now, it could be applied as an inlay or as an overlay. So I have videos for both. This I have borrowed this video. So here we are harvesting a portion of, generous portion of tenons, especially from the inferior temporal or infranasal sector. And then we have to make an intrastromal pocket. We have to clean the surrounding tissue and make an intrastromal pocket. And then this is, once the intrastromal pocket is made 360 degree, this tenons is kind of fit into the intrastromal pocket so that it covers the perforation well enough, and it also has some amount of supporting tuck on all sides. Then once this is tucked in, this is kept in place by X sutures, by cross sutures from healthy cornea at diametrically opposite sides. And then again, this is covered with BCL. Now coming to the overlay technique, again, similarly, the Tenon's tissue is harvested and then it is just sutured onto the cornea so that it covers the area of perforation or the area of thinning adequately. It's sutured onto the adjacent healthy cornea. And once this is sutured, so this is how it looks. So we could apply a little bit of amniotic membrane. This is what I do. Apply fibrin glue on it, then apply amniotic membrane, so that makes it less vascularized. It also gives a little bit of antibacterial property to it. And we can always see the pathology underlying even during follow-ups. And then the host bed is again sealed with fibrin glue. So these are some of the pictures of Tenon's patch graft in impending perforation. So this is how it has done 2 weeks, and I'm sure it will do better as time goes. Some of them would need a PK later on, optical PK. So what we are doing essentially when we are doing a Tenon's patch graft or any amniotic membrane transplant is we are buying time. Sometimes we are able to convert a therapeutic PK or a tectonic PK to an optical PK, and sometimes we can do away with it. If the opacity is somewhere not in the center, we can do away with it. Or sometimes if we are left with a nebular opacity also, we do not need to go for a PK later on. Now coming to the tectonic keratoplasty, perforations more than 5 to 6 millimeter would require a tectonic support. This could be in the means of a full thickness graft or a lamellar graft. And we can have this as a patch graft or a large graft. Now, tectonic support, a corneal tissue, a transplanted corneal tissue gives tectonic support as well as would reduce the microbiological load in microbial keratitis. It can give tectonic support as well as gives time to address the underlying etiology and other causes of non-traumatic corneal perforations. What is of prime importance here is the timing of the graft, the sizing of the graft, and taking adequate care of the visual axis. We must try and ensure that we do not put too many sutures in the visual axis, which will defeat the basic purpose itself. So whenever possible, we should try and do such a graft that doesn't put sutures in the visual axis. And if we feel that we have to put in sutures there, then it's better to go for a larger size graft, especially if you're thinking of a patch graft. Now, these are some pictures of the patch graft. The first one is, you can see here that there's an extensive area of thinning and loss of stromal tissue here. Since there is no real perforation, a very small micro perforation in the center, we can do away with the lamellar graft here. And here, the surgeon has chosen to give a large graft here, where we are left with a thinner opacity or less denser opacity here. And there are no sutures and the visual axis is taken care of. Here, however, there we see there's a patch graft here, which is mid peripheral. And we just have a few sutures here. So every time we have to take it on a case-to-case basis. Suppose this has been on a nasal sector, this would not be ideal, but it could be on the inferior temporal sector. So it does not disturb the visual axis as much. And wherever we feel that we cannot do anything about a patch graft, we can go for a large graft. So this is a large therapeutic graft. Now coming to how does one do a full thickness patch graft? Here it's very important to get the right shape and the size of the patch. So here, especially when we have peripheral thinnings and peripheral perforations like this, like we have in Murens or we like have in collagen vascular disorders, then we have to take a crescentic graft. We have to measure the outer diameter and the inner diameter and take the maximum width of this graft. So this would what our plan would look like. So we would use a trephine of the same diameter, but then make it such that we get a crescentic donor graft out of it. So this is how we fashion a graft. Sometimes we just have to make an imprint of it. And this is how it would look pre-op and post-op. Now coming to the lamellar patch graft, it could be planned or sometimes it could be unplanned also. So like this is one case where I was planning for a lamellar patch graft. But then on table, I had a perforation. Sorry. This is where the perforation happened. We can see that the air bubble escaped and the AC shallowed. And then I was left with two choices, either to go for a full thickness patch graft there or a partial thickness patch graft. Since I still saw there was some residual stromal bed, I decided to go ahead with the partial thickness patch graft. So this is how it was sutured. And end of the procedure, I had a partial thickness patch graft there. So my take-home message for all would be that in spite of such varied options and guidelines available for managing corneal perforations, one may still need to think out of the box, use a combination of techniques and re-strategize whenever needed to give the best possible chance to that eye. Prevention is always better than cure whenever possible. So if you are dealing with a case that is impending perforation, it is always worthwhile to take care of that impending perforation before it actually becomes a perforation. And I have some references for all. In addition to your textbooks, you could always go up with some of these references of mine. Thank you all.
Thank you, Dr. Das, for that excellent coverage of corneal perforations. You've shown some very wonderful illustrations and surgical videos, and it was a very, very complete and comprehensive talk. Thank you so much, and congratulations to you. Also, at the end, you mentioned that impending perforations should be dealt with very quickly. So we have a question here that what is the management of an impending perforation? Would you take, what is the treatment modality?
So again, that again depends on the etiology of the case, the etiology and the sizing and the location. So most of what I said about the surgical management would apply there. We have to first address the causes of the etiology of the impending perforation. Like if it is an infection, take care of the infection. Also give supportive treatment in the way of doxycycline or a bolus dose of vitamin C to take care of the collagenolisis. Then if we see a case of impending perforation, we can always go for a TABCL or else again Tenon's patch graft. Like we must do the same thing before it perforates. So it always gives a better prognosis. So once there's a perforation, there's always chance of increased intraocular inflammation and infection, and also the chance of forward movement of the iris lens diaphragm. So always addressing a case, observing a case, and taking the right decision at the right time is of vital importance.
Thank you so much. So I'd request you to stop sharing your screen, Dr. Das.
Thank you.
So with that, we move on to our panelists for their perspectives on this topic. So I first invite Dr. Alok Sati for his views and comments or anything that you'd like to add, sir. You're muted.
Yeah, firstly, the Dr. Aishwarya has stated about the Seedles test. Herein, I would like to clarify that if the Seedles test is negative, it doesn't mean that there is no full thickness, perforation or full thickness laceration. At times what has been seen is that there is a full thickness laceration oblique perforation, but the Seedles is negative. So in that scenario, one can, little bit apply pressure onto the globe and clearly see whether the perforation is actual or not. So that's one, because it's a teaching program. So that's why I want to highlight, especially to the PG residents, because this is what the wrong notion, especially I have seen in my PG students. That's one. Second, regarding the impending perforation, it's rightly stated that the impending perforation has to be treated according to the cause. But in most of the scenario, even if it is an infective case, it's always advisable to apply TABCL immediately, even on slit lamp. Need not take the patient to the OT, because I have seen myself that there is a desmetocele. The patient is doing well. While taking to the OT, I don't know what happened, maybe because of, block or something. There's a perf, and then the whole purpose gets defeated. So whenever we see a desmetocele, it is always advisable to put the TABCL on slit lamp. These are the two comments which I want to make, ma'am. Thank you.
Thank you, Dr. Sati. I now invite Dr. Josephine Christie for her perspectives on this issue.
Yeah, thank you, Dr. Pinto. So Dr. Davies' presentation was really excellent, covering the vast topic very well. So one thing that I'd like to add is when we are using TABC cyanoacrylate for perforations, and it is very important to note the etiology, and especially if we are dealing with infectious etiology, these glue and BCL will give you a wrong impression that everything is fine. You might not note how the infiltrate is spreading behind, and so that has to be kept in mind. You have to be really careful. And when applying TABCL, a very small amount is sufficient. You need not apply a very, very large, a micro drop is sufficient to seal these perforations. A larger one is always not required. It will also help us to give a better view on the TABCL. You will know how the infiltrate is progressing if it is just a small one and impending perforations. And in my experience, smaller perforations work very beautifully with TABCL. It nicely heals. And usually, what is the timing to remove it? Usually, I wait for the TA to actually dislodge on itself. Usually, it will take 3 to 4 weeks. During that time, we remove the glue as well as the BCL. And yes, as rightly pointed out by Dr. Devi ma'am, high amount of inflammation will be noted whenever you're using these cyanoacrylate glues. So that also have to be kept in mind when you're treating these perforations. Inflammation also has to be kept in mind. Otherwise, it is very nice. One question to Dr. Devi ma'am was like these Tenon patch graft after it is healed. When you proceed for an optical keratoplasty, because you will have a lot of vascularization in these grafts, do you have any specific precautions for these patients to be planned for before an optical PK? Also to other panelists, I'd be happy with your inputs.
Tenon patch graft, in my experience, as also as per literature, has been shown to show less inflammation as compared to a TABCL. So the way we would go about perforation sealed with a TABCL, it would almost be similar to that. And sometimes with Tenon's patch graft, especially with mid-peripheral and peripheral perforations, we may not need to go to a PK later on. Sometimes we can do away with the PK, like a nebular opacity or a nebular macular opacity with 618 vision odd is better than a 6-9 vision with a full thickness graft. So sometimes in my series, actually, most cases I do not have to go for a PK unless like it's for a central graft where the patient is not willing to go for not willing to go for a PK or something. In desperate cases, I may have to give it for a central one. Otherwise, it behaves almost like a TABCL, post-TABCL, or in fact better because the vascularization is much less than that. That's what I have to say. Panelists, please.
So the other panelists, if you would like to add something to that. Revati ma'am.
What Dr. Devi said is correct. Only tenoplasty, especially when the first video what she showed as a standalone tenoplasty, where it is completely removed and placed over. And you may have slight opacity, but you won't have much vascularization. But in your second video, it's like a pedicle graft. You pulled over the thing from the limbus. That's what I noticed. I don't know whether later you trimmed that area away. In such cases only, you may get vascularization. So in that case, the second one, overlay, where you pulled over from the thing, it's like a pedicle graft. In such cases, there may be vascularization. But ideally, those kind of procedure can be done for peripheral perforations, where you need not bother about a later PK. But if it is more towards the visual axis, maybe you can do it as an inlay. Even with the inlay, most of the time it stands very well. So almost in my practice, I almost stopped using, especially cyanoacrylate glue. I use tenoplasty or AMG, multi-layered AMG for these cases.
Thank you,
Same
ma'am.
here,
If I'm allowed, like one more comment, when you are
can I make a comment? Yeah, so can I make a comment?
Yes, please go ahead, ma'am.
Yeah, so I think that was an excellent presentation, Aishwarya. So basically, I think the point is that there are a couple of things that I would like the PGs to also understand about all the basic about these things that we discussed. One is, I think, about the history. Can't emphasize less because we know it could be traumatic, it could be infectious. These are obvious causes. But when you actually have somebody with a arthritis, generally they present you with perforation, and quite often we may not even know that they are candidate of perforation. So it's always good to also look at the tear film and staining if possible. That will give you an idea with a good history taking, because control of the systemic condition should be done in tandem along with the treatment of the perforation. Of course, you cannot wait to take care of the perforation after the control, but you prefer both of them going in parallel. Number one, I think as far as the glue is concerned, one has to differentiate whether you're dealing with a glue, a desmetocele, of a recent onset, or are you dealing with a chronic fistula? Because in the case of a chronic fistula where it's a leaky wound for a very long time, your glue is really not going to work, whatever you do. So how do you differentiate that? You will have history, you will be able to understand. You can look at the anterior chamber to see whether AC details are clear, they are formed, other findings of chronic inflammation like PAS and other things. When you take, if your AC is shallow and you want to do a glue, you want to take up these patients preferably in the OR as much as is possible. Keep the eye patch before you do whatever topical anesthesia or whatever, before you keep the patient ready, and you make a very gentle paracentesis and a very controlled air entry. That's most important, because you have a desmetocele and you just suddenly introduce a large burp of air, it will cause worsening of the perforation. Like Aishwarya said, then your surgical technique has to change from glue to something else for which you may or may not be ready. Very valid point about the glue infections that Dr. Christie made, because while you may feel that the patient is all right when you apply glue for infective causes, very important to get a good history about the symptom of the patient. Keep looking, because although we think the glue has antibacterial properties, there is every possibility that the infection is worsening underneath because the medications don't penetrate as much, and on top of it you have a bandage contact lens that is going to make the penetration of the medication very difficult. As far as the Tenon's graft is concerned, I think it's important to examine the conjunctiva very well, because sometimes we can have etiologies which have dense conjunctival scarring who may have perforations. So you have to look at the conjunctiva in detail and decide on which area you're going to choose when you do the Tenon's patch graft. Like Madam said, and the other panelists said, I think the vascularization could happen in some cases, but quite often it leads to scar. And if the scar is mid peripheral or peripheral, it really may not be so much of a bother as far as the visual outcome is concerned. AMT for a central perforation, one has to remember that sometimes it tends to biointegrate. And when it biointegrates, if it's a slightly large perforation, it can leave behind a fair amount of opacity in the cornea, which I think you will have to address later on. But the possibility of this happening is very less. One word about the patch graft is, I think quite often, like Aishwarya said, the iris is stuck to one area of the perforation. So when you go inside and put in a little bit of air, if it is a chronic long-standing desmetocele, then it is important to remember that you want to abscise the iris. Why you have to, so you make the trephine before you do this, because once you release the iris, the chamber will collapse. Why you have to abscise it? For two reasons. One, you may have epithelialization on the surface. When you try to push the iris inside, you will carry the epithelial cells into the anterior chamber. And the second important thing is that is always a foci of infection, because it's been chronically exposed. So for all these reasons, you want to be very careful before you actually push the iris back after trimming. Debride the epithelium nicely and then go ahead with your patch graft. That's it from my side. Very nice presentation.
Thank you,
Can I
ma'am.
add only one
Yes,
more
Dr.
point?
Dr. Revati, ma'am, please go ahead
Yeah,
with your
yes,
words.
first I congratulate Aishwarya. It was a very lucid and very clear presentation on this
Ma'am,
topic.
if you could, excuse me, ma'am, if you could turn up your volume, it's a little on the lower side, the volume of your laptop.
It's full already.
Okay. Okay.
Am I audible now?
Yes, ma'am.
Yeah. One is, Dr. Aishwarya, I really congratulate. It's a very lucid and very clear presentation. Only one more point I want to add. When we do all these things, at the end, we have to sweep the angle of the anterior chamber gently with a spatula. because often, especially if the perforation is there for even few days, a peripheral anterior synechiae would have formed. At this, if we intervene early, at this stage we can break it. Otherwise, you may end up with secondary glaucoma also. So it's better to sweep that area. If it is a long-standing one, we have to think about doing a PA also. Thank you.
Thank you, ma'am. We have some questions in our chat box. So one question to the panelists is, what is the management of perforations due to autoimmune disorders? So, Dr. Josephine, would you like to take that?
For autoimmune disorders, actually smaller perforations, usually these are little, they won't be okay with just a PABCL. So I usually prefer smaller lamellar patch grafts when it is in the periphery. So, and it really works well. As Rama ma'am had specified, it is very, very important because I recently had young child come with perforation. She had severe blepharitis and it was a marginal keratitis kind of an inflammation, landed up in a perforation. And the father was completely unaware and the child also was completely unaware of the symptoms. And we took the patient for lamella patch graft and the child did really well and we treated the blepharitis also very well. But then again, the patient came up with similar complaints and again the patch graft was trying to getting melted. So it's very, very important that the family is also made known of the etiology and the lid hygiene, and they have to be really explained about what is actually aggravating it and what is actually leading to it. So the trick in treating autoimmune perforations is not done away with just one-time surgical intervention. It is before, after, and long-term management that is very crucial for these patients.
Anyone would like to add something?
Yeah, if I can add a quick comment. Yeah, so I think when you have a systemic immunological disorder, like we already said, the control is important. We also have to address the ocular comorbidities that may come along with it. Besides the perforation, you can have dryness and other comorbidities. So you have to address that either you do a punctal cautery or depending how dry the eye is, sometimes tarsorrhaphy. So it will depend on a case-to-case basis. But as such, the perforation management, I don't think is very different. Different from what Dr. Aishwarya said in terms of how the perforation it is small, you can do a TABC, AMT, and quite often I think, I'm not very sure about AMT, it works sometimes, but you may end up doing patch grafts in some of these eyes. But remember to address the ocular comorbidities also, along with the systemic comorbidities and the perforation.
So in these cases, would you like to step up the immunosuppression that a patient with autoimmune disease who's come with a perforation? Would you like to look at that? Or any, ma'am?
May I?
Yes, please.
Yeah, sometimes if the patient is the known case of some autoimmune disorder or collagen vascular disease, then patient would have already been on treatment. If the patient has never been diagnosed, then the management of the corneal perforation as well as the workup towards the immunological cause has to be done simultaneously. And sometimes we may have to step up the steroids, even IVMP can be given. Because these cases can, the cornea can melt away, straight away melt. So sometimes we have to step up the steroids and then the patient has to be kept for long-term immunosuppression like steroids or non-steroids.
Okay. We also have a question on bioengineered cornea. So what is the latest, what is the what's happening in this field? I would like to know from the panelists. So anyone can go ahead. Are you using bioengineered or is there some headway being made in this field? Dr. Josephine?
I think I have not had any experience with bioengineered corneas, but there are a lot of research going on to it. So having, having it using like a gel and then it forms like a cornea and all of those things. It is all in research. I have not had any experience in that. Probably Dr. Aishwarya ma'am can add onto it.
Dr. Aishwarya?
Yeah, I've just read it up, but it still stays beyond common man's reach. In India, I don't think we have any bioengineered cornea. Revati ma'am and Rama ma'am can tell better because They would have access to it first.
No, we don't have any personal experience yet.
Okay. Thank you so much.
Yeah,
And
but I think I heard about
ma'am?
this. I think I heard about this something from China, this porcine corneal thing, which is decellularized and can be used for this kind of things. But I think in our scenario where we get enough corneal tissue mostly, and also as Dr. Aishwarya mentioned, we have other options like tenoplasty and other things where even readily the donor tissue is available. We can do all these things better than porcine, I mean, an allow graft. It's better to go for such more
Thank you.
same xenograft instead of xenograft. Yeah. Thank you.
Also, we have another question that what are the tissues that can be used for a lamellar patch graft? So do you use a freshly harvested cornea, or do you use preserved cornea, or even smile lenticules are being used? So what is your
Yeah.
take on that, Dr. Aishwarya?
Fresh cornea, of course, would be ideal. If you don't have that, we can go for any even poor quality, poor grade cornea, or even a glycerin stored cornea. There are case reports of even sclera being used there. Lamellar sclera being used there in the absence of any autologous sclera can be used if the perforation is small. And sometimes with larger perforations like less than 3 millimeter but larger and which do not hold up with just cyanoacrylate glue, there are studies which have shown that the sterile drape can be cut and cyanoacrylate glue applied, and that can be used as well. These are for very smaller perforations.
Okay, thank you so much. So if any of the other panelists would like to add something to this topic before we move on to the next talk. Okay, so I'll share my screen and invite the next speaker now.
Thank you all.
Thank you, Dr. Aishwarya, and thank you for the wonderful discussions. So with that, we move on to our second talk for this morning, and that would be by Dr. Tarun Sood. So to give you an introduction to Dr. Tarun Sood, he is presently working as assistant professor in the Department of Ophthalmology at the Indira Gandhi Medical College in Shimla, and is a cornea, cataract, and refractive surgery consultant. He did his MS in ophthalmology from the Indira Gandhi Medical College in 2014 and subsequently went on to do an MCH in cornea, cataract, and refractive surgery from PGI Chandigarh in 24, followed by a FAICO in cornea in the same year. He's also done a 6 weeks observership in ocular surface at the Code Eye Care in Chennai very recently in 2024. He's also an avid writer and presenter. And today he'll be speaking to us on therapeutic penetrating keratoplasty. This is another very, very important topic for the postgraduates, not only for them to know theoretically, but also to know practically. So looking forward to your talk, Dr. Sood. I invite you to share your screen.
I hope I am audible and my slides are visible.
Yes, doctor.
Am I audible and my slides are visible?
Yes, both, sir.
Okay. So, first of all, I would like to begin by extending a thanks to Dr. Santosh Shunawar and team AIUS for considering me worthy of presenting this topic on this platform. And also, I'm thankful to Dr. Tinku Bali ma'am for such a generous introduction. So, I'll be starting this topic with a simple definition. Now, the definition of therapeutic penetrating keratoplasty states that it is a procedure in which you excise a full thickness button of diseased cornea and replace it with full thickness donor tissue. As simple this definition seems, the procedure is not simple. Rather, the procedure is more complicated than doing an optical graft. Why? Because you are operating on hot and inflamed eyes, you have to put 24 to 36 sutures at a time. You have to take lens out. You have might need your vitreoretina colleague help. So it is not as simple as optical penetrating keratoplasty. It needs more of skill set, and hence it is very important for a PG student to understand this in depth, that how therapeutic penetrating keratoplasty is done and what are the basic prerequisite and what are the basic goals of this procedure. So goals are pretty straightforward and simplified. We have to eliminate in total the infectious and the inflammatory disease process which has led to corneal melt. The second goal is to preserve the tectonic integrity of the globe to prevent it from going into phthisis. And third is, in case your corneal scrapings are not able to tell that what the pathology is, this is definitely going to help in most of the cases. For the ease of understanding, I have divided this presentation into 4 topics: indications, the surgical technique, the post-op management, and the complications of therapeutic penetrating keratoplasty. Now, the indications. When it comes to indications, we have to be pretty sure whether to do a TPK or not do. Because if we can get off simply with a medical management, or as ma'am told in previous talk with glue BCL or with Tenon's patch graft, then why end up with a TPK? But there are certain set of indications where the TPK is mandatory, and there are certain sets where you can just go off easily with medical management or maybe a glue. So the indications where TPK has to be done are infectious keratitis, which are refractory to treatment, as in bacterial, fungal, and viral organisms, and less commonly seen acanthamoeba, nocardia, and pythium. Also, if the melt is worsening despite your maximum medical therapy, then you have to consider for therapeutic penetrating keratoplasty. The non-healing ulcers secondary to neurotrophicity, exposure keratopathy, and severe dry eye. That again forms an indication for doing a therapeutic procedure. And large corneal abscess, progression with risk of limbal or scleral extension, desmetocele, and progression to endophthalmitis. These are straight away indications of therapeutic penetrating keratoplasty. These are no brainers. You have to just do a TPK. Only that is the only definitive treatment. Now, with these are the pictures which will probably help understand a PG student better that whether to go for a TPK or not go. In the first picture to the left, you could see that there is an corneal exudate and infiltration along with the perforation, the iris tissue plugging the perforation, a desmetocele. So you have, this is despite giving the maximum medical treatment. So you cannot wait more and you have to do a TPK. In this picture, you could see a dirty whitish looking infiltrate with a central thinning. It was progressing despite maximum medical management, 2 weeks. So you have to take a call for TPK. Similarly, in this case, your infiltrate is encroaching onto the limbus. Once it reaches the limbus, you'll have to put more of the sutures. Once it extends the limbus into the sclera, it puts the globe into the danger of endophthalmitis. So this is the stage where you have to decide that now we have to do TPK. So that is why the timing of surgery is very crucial for TPK. When there is a corneal abscess and this corneal abscess is non-respondent to any kind of medical management or any kind of other intracamera's or intrastromal injections, then you have to consider for TPK. When the tectonicity or integrity of the globe is at stake, like is in these 2 pictures, there's a pseudocornea and there is the whole of the cornea is melting and a pseudocornea is formed, you are not left with any choice apart from doing a therapeutic procedure. Now, these are the 3 pictures which help you understand that here you can very easily avoid this procedure. The very first picture here, you could see a grayish white infiltrate with few satellite lesions. This is most likely a fungal ulcer. You start the patient on antifungals and it will respond very nicely. Secondly, a overlooking ulcer with a retrocorneal exudate and a hypopion. Most likely it will be bacterial and your medical management will solve your problems. This is a post-viral thing where the infiltrate has healed with the vascularization very nicely. So why to do a therapeutic penetrating keratoplasty when you can later consider this patient for optical? So the point is to understand where to do a therapeutic penetrating keratoplasty and where not to do a therapeutic penetrating keratoplasty, because the surgery comes with its own set of complications. So you have to you have to be very clear in mind that when to do and when not to do. Like any other surgery, the pre-op evaluation obviously forms uh, the basic part of this surgery as well. You have, as ma'am told in previous talk, the detailed history taking it is very important. Apart from that, you have to take a note of RBS, RFT, LFT, and BP checkup. Why this? Because an uncontrolled diabetic status will lead to persistent epithelial defect. It might worsen end off, or it might cause recurrence of infection. If your BP is not in control, you might have an suprachoroidal hemorrhage while you are operating. And since you are supposed to put this patient on systemic antimicrobials prior and after the therapeutic penetrating keratoplasty procedure, you have to note whether RFT, LFTs are in range, because they can worsen with treatment as well. The second is that you have to see the size, depth, location, and extent of infiltrate, whether the limbus is involved, whether the sclera is involved. And one most important point is the presence of AC exudates. Now, the logic behind this is that if your AC is studded with exudates, sometimes you are not able to make out what the actual extent of infiltrate is. So once you take those AC exudate out during intraoperatively with the help of Simco, then you realize that that the infiltrate is not that big, and then your definition seems to be more accurate. Apart from this, if your IOP is increased preoperatively, you are predisposing the patient to the risk of expulsion of intraocular contents. And the status of lens has to be known, whether it is clear, whether it is intumescent. We'll be dealing with this in the subsequent slides. And the third point is ultrasound B scan. B scan is a must because it helps you rule out endophthalmitis. It helps you rule out if there are any choroidals or retinal detachment. These all are important because they will help you prognosticate. They will help you explain the patient better that what the outcome could be. And you yourself in your mind know that what is the outcome. These also help you decide whether you need a retina colleague to intervene in between, or whether you can just manage on your own. Systemic and topical antimicrobial treatment is to be continued throughout the procedure. Intravenous mannitol is a must before you take up a patient for any kind of penetrating keratoplasty procedure. It will be 20%. It will be given slow over 30 to 45 minutes prior to procedure. If the age is less than 12 years, it will be 2 gram per kilograms, the dosage. And if it is more than 12 years, it will be 1.5 to 2 grams per kilograms. And thirdly, you cannot ignore the very important considerations, which are anesthesia and donor tissue related. Now, the general anesthesia is ideal choice in such cases because you are at the risk of positive vitreous pressure. However, you will not always get general anesthesias. In small cities, in small resources settings, you will have to revert to local anesthesia at times. However, there are certain conditions where you will opt for general anesthesia only. And these are the large corneal perforations, the desmatoceles, anterior staphloma, large grafts, young or elderly, frail, uncooperative patients, and expected prolonged surgical time. Local anesthesia, if you opt to, you can supplement it with facial block. Intraoperatively, you can supplement it with subtenon. You have to ensure that your block is prolonged and your block is effective, because this procedure is going to take time. You will have to do significant amount of intraoperative manipulations. You will have to form AC. You might have to clear vitreous of the infective exudate. You might have to expel the lens out. So you are going to have some time, plenty of time to do all these procedures. So it is better to use a mixture of lidocaine and a longer acting anesthetic such as bupivacaine combined with hyaluronidase, epinephrine, and sodium bicarbonate. You have to do a very gentle massage because even the slightest or minutest of the pressure will lead to the expulsion of the intraocular contents, and whole of the purpose will get defeated at the table only. Now, the donor tissue related consideration. Having said that the donor tissue requirements are not as stringent as in optical, and you will always try to have a good quality donor, A or B positive, with endothelial count more than 2000 cell per millimeter square. But practically speaking, this is not always possible. We are already having scarcity of donor cornea, so you cannot always demand a good quality donor, and you might at times will have to use a therapeutic grade only. And the advantage of getting a good quality donor is that it will help maintain a clear graft in spite of inflammation or raised IOP. The epithelium will be good, and there will be the chances of having epithelium related issue post-ops will be less. Again, there will be reduced chances of graft reinfection. However, poor quality donor is most of the times used, and it is used because the procedure is an emergency requirement and you do not have an access to good quality donor always. Alternatives, as discussed prior, are cryopreserved tissue and glycerol preserved cornea. And anytime the primary aim of a TPK is not visual rehabilitation, and down the 6 months or 1 year down the line, the eyes cools down, you can always do a optical penetrating keratoplasty. Now, there are 4 basic steps of therapeutic penetrating keratoplasty. First is ensuring proper exposure of the surgical site. Second is recipient bed preparation and trephination, followed by donor button preparation, and finally, the placement and suturing of graft to tissue to host bed. Now, for ensuring proper exposure, you use a self-retaining speculum. But in case you feel like that the lens is popping out or the things are popping out, you can simply go with traction sutures on lid, or a flaring ring which you can suture to healthy sclera is a very good option. You might have to do conjunctival handling in cases of large grafts where you will need to do peritomy, and for hemostasis you should always be ready with a wet field cautery because there will be so much of bleeding that it will become messy to put sutures or to do manipulations. 1 drop of topical primolidine is supposed to arrest bleeding by causing vasoconstriction. Now, coming to recipient bed preparation, you have to measure the involved area using the caliper in the largest dimension. The important crux is in the largest dimension so that you involve whole of the infected area. And then you have to place the appropriate trephine over the cornea, creating an indentation in the cornea. And this indentation has to be just the slightest impression. You can use your marker to make a mark on the sharp edge of the trephine so that you just get that gentle outline, that slight outline. And then your trephination is to be centered over the infection, so as you leave the maximum non-infected tissue between ulceration and the recipient bed. Make sure you take 1 mm of healthy tissue also, because there might be some submicroscopic foci. So you have to take 1 mm of healthy tissue all around and leave a stable non-infected recipient bed to which the suturing could be done. The initial recipient definition has to be 75 to 80% depth. Now, why this? Because if you do a complete 100% definition, there will be instances you will be handling perforated corneas, thinned out corneas. In these cases, if you do 100% definition, you will never be sure of the depth you are reaching. You might trephine the lens, the iris, the ciliary body, the zonules, and this is not something which is intended. So your definition has to be 75 to 80% depth, and then a guarded entry should be made into the AC with 11 number blade. The viscoelastic is to be installed, and then you can cut your rim with the Castroviejo scissors, right and left-handed. Alternatively, you can use corneoscleral scissors as well. You can use curved Vana scissors as well, and then carry on the dissection along that definition. The blades can be perpendicular or they can be slightly angulated. You have to remember that in case you are doing a large graft, you have to leave a relatively wide posterior ledge near 1 mm because it will help in in graft host bed apposition, providing it will further reduce the risk of post-op leakage. Now, the very first picture this shows that how a gentle outline of the trephination of the area to be trephined is done. And most of the times we are very convenient using the handheld trephine. Their cost factor, it goes down. But if you have assist, then you can use these suction trephines. The logic is that these suction trephines, they are centered on limbus. And so the trephination by these suction trephines is very predictable, slow, and very guarded, in contrast to the trephination done by handheld trephines. But since if there is any cost constraints, which obviously in this subset of patients you will face, so you can use the handheld trephines. So this is how you do the trephination. You very gently place the trephine on the marked area and give the counter traction and hold the globe using a lens forceps, and then apply a gentle pressure with that the pressure distribution between your thumb and between your index finger should be equal, so that you cut in an even fashion. And once you have done some 70-80% of the trephination, you put the viscoelastic and then you make an entry with 11 number blade, extend it slightly, and then cut with the Castroviejo scissors along the curve. Once you have cut, and then you can put the donor tissue over the host bed after you have made the AC and form the angles, which we will be discussing in subsequent. Now, recipient bed trephination and preparation has its own set of some particular challenges. It is not so easy if you are coming across conditions like corneal necrosis, gross thinning, axial perforation, loss of scleral rigidity, low intraocular pressure. So one simple thing, if you come across a perforation, you can put cyanoacrylate glue. It will make the AC, it will form the AC, and then you can do, then you can put viscoelastic and do the trephination. In case you land up with vitreous in AC, you have to do anterior vitrectomy. Some large ulcers with limbal extension will warrant a freehand dissection. Now coming to AC reconstruction, you have to gently profuse whole of the AC with BSS, because it will eliminate all exudative material, and it is only this exudative material which, if left, will prevent the recurrence of infection and complications such as secondary glaucoma in the post-op period. The dissection of membranes over the iris has to be done with the irrigation cannula and then with the McPherson forceps very gently, so as to ensure that there is minimal bleeding from the iris, because it will then in the post-op period you will see hyphema. The angles have to be freed of adhesions. At any point, at any cost, you have to make the angle free of adhesions using the viscoelastic 360 degrees, because not only you have to break all the synechiae, you have to ensure that you form a deep AC and there is no leakage. In therapeutic penetrating keratoplasty, 2 large PIs have to be done so that you do not see any spikes of IOP in the post-op period. Lens considerations are very important. If your lens is clear and crystalline and is not infected, please leave it in place, because it will provide a barrier against vitreous seedlings and infectious endophthalmitis. In case your lens is infected or there is an inadvertent lens extrusion due to positive vitreous pressure, you can do an ECC. In case of endophthalmitis, crystalline or intraocular lens removal along with total open sky vitrectomy along with intravitreal antibiotics, injection vancomycin and ceftazidime is the standard protocol. 2% pilocarpine you can always use if you fear that the crystalline lens is going to pop out. Free use of intracameral antibiotics and antifungals has to be done wherever it is indicated. And in case of significant chamber shallowing with positive vitreous pressure, pars plana vitrectomy can be used. Now coming to next step, that is preparation of donor cornea. Now you have to remember this, that donor trephination in TPK is done only after excision of recipient cornea. Why? Because necrosis of wound edges may require additional trimming and hence the final size may be different. So you have to trephine as a postgraduate student, you have to trephine the donor only after TPK only after donor recipient bed is prepared. And there is a set rule for the trephination of donor cornea. In case the recipient bed is up to 10 mm, the donor has to be 0.5 mm larger than host. In case it is more than 10 mm, it has to be 1 mm larger than host. So this is how you can always use a RK marker, RK marker, because it will help you exact placement of the suture, the radial placements of the suture. So this is a Teflon block. You place the the donor tissue over the Teflon block, and you make sure that you wipe out the MK media, whichever is coming along with the corneal tissue, with the help of a Miracil sponge, because in case even the smallest amount of that media is there, it will lead to spillage. And when the Teflon bed is dry, you again put the donor tissue and then trephine it by first holding the Teflon block between the thumb and the index finger of the left hand, and your right hand, with the thumb of your right hand, you provide a gentle firm downward pressure. And when your donor, and you will see that your donor tissue has been perfectly cut, you can put some chondroitin sulfate on it, because it will help prevent desiccation, as well as the endothelium will be protected. Now coming to the last part, the suturing. The suturing is done with interrupted nylon filament, Tenon or Nino sutures. It is not advisable to put a continuous suturing, because when one of the suture gets infected, you need to take out whole of the suture. The radial placement is preferred. However, the utmost goal is to have a good apposition. So if at the cost of cosmesis, you can still put some sutures here and there, but you have to achieve the integrity. You have to achieve that good AC good AC and that the wound is not leaking at the end of the surgery. The suture should be at least 75% depth. The longer bite sutures are preferred. Suturing has to be done with moderate suture tension, so as cheese wiring of sutures through a potentially inflamed host bed is avoided. And in case your graft is less than 9 mm, you can get away easily with 16 sutures. For more than 9 mm, you can put 24 sutures, but 16 and 24, again, not a rule. You can go from 16 to 17, 18, 19, whatever number it needs to form the AC, to ensure that there is no leakage. Integrity of wound is to be checked at the end of the surgery. And when you are done with the procedure, your host rim will be divided into two parts. One part will be sent for histopathological examination in formalin, and other part will be further divided into two smaller parts, and one part will be sent for bacterial culture sensitivity and gram staining, and the second part will be sent for fungal culture and KOH. Now this is how it looks like after 8, 12, and 24 sutures. So coming to the post-op management. Post-op management is equally crucial as was the intra-op part. Why? Because if your post-op management is not rational, you will end up with innumerable complications. First of all, coming to bacterial keratitis, you can initiate systemic antimicrobials 1 day prior and continue it for 2 weeks. For fungal keratitis, you can initiate 1 day prior and continue for 2 weeks. You can consider 6 to 8 week therapy in cases with pre-op perforation, hypopion, limbal, or lens involvement. In viral keratitis, you can give acyclovir for 400 mg 5 times a day, followed by 400 mg BD for 6 to 12 months as a prophylaxis for herpes simplex virus. Coming to topical antimicrobials for bacterial keratitis, 1 hourly antibiotic depending upon the sensitivity, or if you don't know sensitivity, then you can use a broad spectrum antibiotic, and then it is to be tapered as the defect is epithelizing. Fungal keratitis, you have to taper the drop over 8 to 12 weeks if no recurrence or epithelization is complete. Viral keratitis, drops are not as effective as systemic therapy for preventing recurrence. Coming to a controversial thing, the topical steroids for bacterial keratitis, you can use 1 to 2 hourly initially under antibiotic cover. For fungal keratitis, there is a caution, withhold for 1 to 3 weeks and initiate the low dose steroids if there is no residual or recurrent infection, if the epithelialization is complete, if your rim on culture shows no fungal organism. So only then you start them on steroids. Viral keratitis you can give safely under antiviral cover. Acanthamoeba keratitis, again a caution, only in cases with severe uveitis you have to use. Adjunctive treatment is cycloplegics, tear substitutes, and anti-glaucoma treatment. Now coming to block intra-op complications, as I said earlier, also this surgery is not immune to complications, so there will be block-related complications, which could be corneal perforation and expulsion of intraocular contents, and other block-related complications, which could be seen with any ocular surgery. The trephination-related complications obviously are unique. They are iridodialysis, iatrogenic aniridia, and eccentric trephination, which is more common in thin or perforated cornea. And expulsion of intraocular contents in perforated cornea can occur with aggressive trephination. So this picture shows that there is a spontaneous expulsion of lens. So this can happen if you have done aggressive trephination or if you have a positive vitreous pressure. Now the post-op complications have been divided into early and late. Early are epithelial, which occur within 2 weeks, such as epithelial defect. Now, epithelial defect can be persistent because at the first place, your donor epithelium is unhealthy. Secondly, your tear film and ocular surface are disturbed. Thirdly, you have done a limbal to limbal graft and there is a stem cell loss. Fourthly, the toxic medications and exposure can again lead to epithelial defects. So what we can do is we can use the drugs which are not toxic to epithelium. We can revert to amniotic membrane, or we can do a tarsography, which can prevent the evaporation and prevent the movement of lids over the cornea. Second most common complication would be wound leak and shallow AC. Ensure at the end of your surgery, put as many sutures as required and prompt resuturing in case you still come across a shallow AC. Suture infiltrates, which could be infective, which could be inflammatory. If they are infective, they will be having an epithelial defect, and AC reaction, they would be solitary. And you need to hike up your antimicrobials. In case they are inflammatory, they will be multiple, they will be on the host side, there will be no epithelial defect, no AC reaction. You just need to hike your steroids and you see them disappearing in a couple of days. Late post-op complications which can occur after 2 weeks could be cataract, glaucoma, graft rejection, chronic inflammation, endothelial decompensation, recurrence of infection, or thysis bulbi. Now, the recurrence of primary infection in the graft, there are few causes which need to be addressed. If you have incompletely excised the infected tissue, if there is residual infected iris or AC exudation, if there is associated endophthalmitis, if there is early administration of steroids, or if there is resistance to microbials, antimicrobials. And the treatment is do an AC wash, put intracameral injection depending upon what your culture sensitivity tells you, or regraft with a larger size in case these previous measures do not work. So this is my last slide, and with this slide, I end my presentation. Thank you.
Thank you, Dr. Sood, for taking us through the intricacies of this surgery. You very nicely and comprehensively covered the subject. Congratulations to you. Excellent talk.
Thank you.
So with that, I invite our panelists for their comments. I first start with Dr. Josephine Christie. Dr. Josephine, you have an excellent publication in the IGO on the long-term, the long-term results of a therapeutic keratoplasty. So I would like you to share your comments on the talk and your perspectives.
Yeah. Thank you, Dr. Tinko. And yes, Dr. Tarun, it was a very, very excellent presentation and very comprehensively covered. I think it was a good start for any postgraduate, any fellow to actually look into your presentation and start. It was very comprehensive. And yes, so having a successful therapeutic keratoplasty, I would say, is deciding at the right time decides 90% of your success. Because the more you delay your therapeutic keratoplasty, the more complicated it becomes. Everything, the surgery per se and the post-operative management, the intraoperative steps, everything becomes complicated the more you delay TPK in a very late stage. So deciding is very crucial. And being a tertiary center, we did see a lot of late presenting ulcers, very severe corneal ulcers, and that is why we found that the more larger the graft, the more the complications are, like secondary glaucoma, endophthalmitis, reinfections, because we're not able to make sure that we had taken out the complete foci of infection. And when it goes beyond the limbus, there is scleral melting, and the entire tectonicity is also gone. So that's why I was telling decision is very important. And when it goes closer to the limbus and you feel there is a suspension of sclera and all, it is good to do a nice peritomy, not only to see for how much it is extended, but also for you to take depth of your suture. Also, it really helps. Don't hesitate to do a conjunctival peritomy. And the other thing is, most of the time, we might be dealing with a very bad ulcer, but you don't have a culture positivity. You don't know what organism you're dealing with. So in that case, it is also good to take your button for culture as well as PCR also. So that will give you some idea of about what exact antimicrobial to use on these patients, instead of giving them a cocktail of medication and you know that none of it works properly. So it is good to follow the TST protocol as per our experience. If it doesn't work, if you don't see any signs of healing, it is good to take TPK at the right time. So these are and in cases of larger infections, if you after you have defined, but then when you're suturing, you feel that there is a small a foci somewhere in the host cornea, you can even give intrastromal oriconazole at the end in that foci to make sure that it is taking care of some antifungal coverage in that particular place. And so these are the common things. And post-operatively, it is very important to actually have a successful outcome when you have a good donor corneal button. So as rightly pointed out, so unfortunately, most of our hospitals, we still go for a therapeutic grade. So therapeutic grade added on with a lot of severe inflammation complicates the entire procedure, entire disease, not only for the patient as well as for the treatment provider also. So you will not know when to start the steroids. So all of it boils down to deciding at the right time and having a proper culture or the microorganism with you. You will be able to treat the patient in a better way.
Dr. Josephine, again alluding to your paper, what are the long-term outcomes of these cases with therapeutic keratoplasty?
So I would say that yeah. So I would say that we shouldn't decide the long-term outcomes based on our paper, because this is one part of tertiary eye care center where we dealt with very severe ulcers, and we did use a lot of therapeutic grade corneal buttons. The outcome was really poor. Almost 90% we were able to 90% we were able to achieve therapeutic success. Like we were able to treat their infections. But then if you see visual success or whether we were able to provide them any useful vision post therapeutic keratoplasty, it was very poor, because that is what as eye care providers we should aim for. So when it gets delayed, the functional success was very poor, but the anatomic success and the therapeutic success was decently good. But the therapeutic success also, only for 60% we were able to give it primarily with primary keratoplasty. For the remaining 30%, we had to do repeat AC wash, repeat intrastromal injections, intracameral voriconazole, or a regraft also. So that was a sad part, I think. But now I think we should not be disappointed with the long-term outcomes with our paper. I think that should give us a learning lesson that when treated at the right time, you will definitely have a good success. But when it is getting delayed, the outcomes are not great.
Thank you. Thank you so much. Dr. Revati ma'am, you also have published extensively on this subject. So I would invite your comments on the talk.
Thank you. And again, I congratulate Dr. Sood for a very good presentation, very clear presentation for the juniors especially. And as Christy pointed out already, most of the points are covered. And very important thing, two things, when to intervene. Usually we always hesitate to go for a surgical intervention in an infected and inflamed eye and try to postpone it as much as possible. That is one mistake sometimes we make. So we should know when it is going out of our hand and we have to intervene. And there is one clue in the mud study papers what Dr. Prajna and all published, in that when you repeat the culture after, in that study, they repeated it after 6 days. But I would say that is too early, especially for a fungal infection. But if you think even after 10 days or nearing 2 weeks, the repeat culture is again showing fungal culture, fungal positivity, that means that fungus is not responding to your medical management. That is one clue. Another one, when a patient present to you late, like already treated, but nowadays most of them already, the even practitioners start antifungal therapy and then send the patient to you. When already they are on antifungal for a week or more, and still if you are able to isolate the fungus in your culture, that means again it's going to be an aggressive one. In such cases, start your therapy, give it a chance for maybe a week or something, and then always keep this in mind that this patient may need a therapeutic surgical intervention, and plan it in the right time. That is one thing. When you are going for a large graft, if it is more than 8 mm, always take a donor button irrespective of the size. Go for 1 mm more donor button than the host area. Because it's usually in these cases there will be trabecular collapse and the secondary glaucoma chances are there. So go for, instead of 0.5, you can go even up to 1 mm larger graft you can go for, and you may need to put more sutures. And in a very large, going up to the limbus, use 9-0 nylon instead of 10-0 nylon. That will give more sturdy anchorage to the button. And as you pointed out, the taken care during the surgery, washing, double PA, and the traditional advice is not to touch the lens. But if the lens is large and engorged, and you have to remove it, but make sure that PC is intact. And already there is, even if there is a vitreitis, need not be an endophthalmitis, it can be a reactionary vitreitis. Need not go for a vitrectomy at the same sitting unless there is a PC rent and vitreous coming out. Avoid entering into the posterior segment as much as possible during the first procedure. As you pointed out, later they may need. And another point, malignant glaucoma, aqueous misdirection syndrome also is very common in these patients. That we have to keep in mind and intervene in the right time. We have to go for a pars plana vitrectomy and then reform the AC. So multiple entries, multiple surgeries may be needed. That has to be explained to the patient and make them mentally prepared for the thing. Thank you.
Thank you, ma'am. Dr. Rama Rajgopal, I invite your comments.
Yeah, so that was an excellent presentation. I could completely comprehensively cover everything that all of us should know, not only postgraduates. So a couple of points have been reiterated by both the previous panelists. A few things that I want to say. I think as part of your preoperative evaluation, we are all bogged down about only the cornea when we have a corneal infection. I think like it was rightly pointed out, two important things. I think the pressure and the retina status, because if it is a phakic eye, we tend to think that that is less likely that it's going to have an endophthalmitis. Very rarely you can see fungal infections traversing through the zonules and causing endophthalmitis. So please remember to do an ultrasound. If it's a thin cornea, please inform your colleague to do it very gently, but make sure you have documented the posterior segment status in these eyes. I think sac patency is one thing that we always do, other than the other tests that he has already mentioned in terms of LFT and diabetic control. Surgically, it's been covered very well. Sometimes if the cornea is very thin, I even try to patch the eyes before the intubation so that it doesn't perforate. It may be a good idea till the intubation is done under general anesthesia. Local anesthesia is a bit tricky, but sometimes you really can't help it if the patient is not fit. As far as the peritomy, I think we cannot emphasize more. When you have large ulcers, even if they are 1 to 2 millimeters close to the limbus, I still prefer to do a peritomy, because sometimes you don't know actually if there is an early entry into the sclera in some of these areas. So a good peritomy, 1 to 2 clockers on either side of where you see the clinical extent of close to the limbal involvement actually helps you, like was pointed out, not only in understanding whether there is scleral involvement, but also in taking your sutures and creating a watertight wound. If you have a scleral invasion, then you may want to decenter your Fleringer's ring accordingly based on the extent of involvement. Sometimes if there is associated scleritis, you can have scleral thinning, so be very careful when you take your scleral bites as well. The other point is about the entry that's already been discussed. Very guarded entry is very important. Also important to see whether there are areas of thinning, because the classical teaching is to go 0.5 millimeter, 1 millimeter beyond the area of involvement. Sometimes that may exactly land on the area of thinning and you will have problems with suturing. So based on the extent of thinning, you can even go a little bit, you can even decenter your graft so that you have a reasonably thick tissue on which you can take your bites. Paracentesis, importance of paracentesis has already been discussed if you have an AC exudate. So once you release the exudate, you'll be able to understand the exact extent of corneal involvement. A careful trephination, guarded trephination is very important. I always like to feel the opening pressure of the eye before I enter, because sometimes you will find with all that you have done, including mannitol, the pressures are still high. So at least under GA, you can ask the anesthetist to give the patient a little bit more mannitol. You wait till you feel the pressure is reasonably under control before you enter, because this one step, if it is not okay, can result in disaster in most cases. None of us want to touch the lens in these eyes as discussed, but sometimes what I find is there is a very thin inflammatory membrane on the lens, and then especially in fungal cases, you find exudates under the iris surface. So what I would like to do is gently peel, without touching the lens, peel off the inflammatory membrane and just retract the iris and see if I can see any evidence of exudation on the lens. This is usually you can see it in fungal cases. Still, you can decide whether to do or not do touch the lens based on the extent of involvement and whether there's actual indication, because once you violate the lens and you can't retain the PC, then you're in for a much bigger disaster. And I think the other points have been well covered. PI, it's very difficult to make PI in these eyes. There'll be a lot of bleeding, but still you make sure that you made 2 really large PI so that we at least counter the post-operative inflammatory and glaucoma related complications. And suturing the donor cornea 90 may be a good idea sometimes when it is really difficult. You prefer to take slightly larger bites so that you create a watertight tube. Sometimes if the area of suturing is in the area of thinning, then you can even make it slightly non-radial so that you avoid the area of thinning. Otherwise, it tends to cheese fire, especially in the area of infiltration. One point I forgot is the angle involvement, because quite often when you clear the exudates, you feel that you have cleared everything. But if you have to look at the angle, because especially the inferior angle, you may have a few exudates sitting there that will not be clinically visible, and that will be one important cause for recurrence. I think the rest of the points are well covered. The only problem is that as a part of your post-operative monitoring, again, it is important to look at the symptom of the patient, look at the epithelial healing of the patient, look for recurrences, look at the pressure, and if you have violated the lens for some reason, look for evidence of post-operative involvement. We do a last word about combined cases. We do a lot of cases where we have to do retina surgery with keratoprosthesis for corneal infection. So in those cases, because there is a limit to the size of keratoprosthesis, we use Landers, which is either 6.2, 7.2 or 8.2. So, and if your infection is 10 millimeters, then we make a smaller opening, fit the keratoprosthesis, get the retina surgery done, and then make the mark and then do a freehand dissection and cut it to the extent of the corneal involvement that is necessary. That's it from my side. Thank you. That was an excellent presentation.
Thank you, Dr. Rama, for those very practical tips that you've given. We have a question in the chat box related to the antifungals that you would use. So most of these cases, as you said, are fungal ulcers. What is your choice of antifungal agent, and would you like to give oral antifungals as well? So, Dr. Josephine, would you like to take that question?
Yeah, so voriconazole is definitely a very good antifungal that we prefer for aspergillus infections and deeper myocardial keratitis. And also, systemic voriconazole will give you a good cover. It will have a good bioavailability. And for fusarium, natamycin is the drug of choice. And in cases where voriconazole as well as natamycin does not work, I tend to prefer antibiotics.
Dr. Revati, ma'am?
Yeah. As I already pointed out, some of these cases may not, the infection is not responding to the antifungal, whatever we have been using. So generally we start with natamycin, and large cases, natamycin with voriconazole topical, or sometimes these cases would have gone already for intrastromal injections, intracameral wash, all these things. Only finally we will be going for a graft. But when we are doing graft, as Dr. Tarun pointed out, maybe it's better to go for oral antifungal also. Because these cases, because we are anyway opening and this We need not bother about aqueous barrier here. So at the end of surgery, also give a good wash, antifungal wash with voriconazole. Generally, that's what I prefer. And then you can add oral antifungal. But generally, we have only azoles as oral. And if the patient can afford, voriconazole oral will be an ideal one because I have seen good results with that. But if it is not, at least the itraconazole, something like that, we can give. Fluconazole generally for filamentous fungi is not that effective. Going for oral fluconazole may not be, if it is a candida or such infection, it's okay, but filamentous fungi, it's not that ideal. So we can, if possible, to add oral antifungal also in these cases.
Can I make a
Dr.
point?
Rama? Yeah.
Yeah, so I think other than this, I think the one definite indication which most of us feel is the role of antifungal is when you have an extensive limbal or scleral involvement and when you have intraocular invasion, like endophthalmitis. Till the time you buy time to get your patients ready for surgery, you definitely want to consider oral antifungals along with the topical medications that has been discussed.
And your choice of oral would be voriconazole again?
Yes, yes. At this point of time, I think for scleritis, I still prefer voriconazole.
And for topical, combination of natamycin and voriconazole or single?
No, I think a lot depends on what stage and what depth and what size. That has already been discussed. I think if you have an early ulcer, which is filamentous, then you may want to just consider natamycin. But if it is a larger ulcer and is more deeper and patient is not responding but is compliant to the treatment, but you still find that ulcer is progressing, then we will have to add on voriconazole, I think. And thereafter, if there is further worsening, then the decision making has to be taken based on the size and the depth and extent of involvement, whether you want to add oral antifungal and wait, or whether you want to go for a therapeutic graft.
And what about amphotericin B? Does that also have a role in the present scenario? Do you still use it?
Yes, we still use it. Actually, we've been using amphotericin for a very long time in our institute, and we do find that it does help. But in the current scenario, I think there are a few patients whom I still prefer amphotericin. But of late, I think the trend is more towards voriconazole, especially if they are not responding.
Thank you. Thank you, ma'am. So thank you for the excellent discussion. And with that, we move on to our third and final talk of this session. I will just share my slide. So this third talk is by Dr. Madhu Uduraju, and he's the chairman and managing director of Dr. Ramana's Raju's Vision Tree at Vishakhapatnam. So to give you a brief overview of Dr. Madhu Uduraju, he is fellowship trained in cornea and anterior segment surgery from the Arvind Eye Hospital, Madurai. Thereafter, he is also done an accreditation in refractive surgery from the Singapore National Eye Center, as well as international fellowships from Unimore, Italy, Linköping University, Sweden, and Harvard, USA. He has the distinction of being the first surgeon to perform Bowman's layer stromal transplant for keratoconus in India. So he has a vast experience and more than 2,500 corneal transplants and an equal number of refractive surgery and cataract procedures to his credit. He's also been a very avid teacher. He's trained DNB students and long-term and short-term fellows. He also has numerous plethora of awards actually to his credit, including the American Academy of Ophthalmology International Education Award in 2020 and the International Scholar Award in 2022. Besides that, he has won best papers and best videos in a lot of international conferences as well as national conferences. And he has been given the Outstanding Ophthalmic Teachers of India Award in 2024 and 2025 as well. So he's been an avid writer. He has multiple papers and publications to his credit. And he also has, to his credit, the CORNEA, which he developed in collaboration with Orolab, which is a device to evaluate corneal donal tissue, and it is very useful for eye banks and corneal surgeons. So that was a very, very, very illustrious background. So with that, I invite Dr. Madhu Uduraju to present his talk on keratoprosthesis. Over to you, Dr. Uduraju.
Thank you, madam. Thank you for that kind introduction. Is my screen visible, ma'am?
It's visible. Yeah. You could make it full screen.
Yeah. Yeah. I firstly thank the team of GuruSangam for giving me this opportunity to present on this keratoprosthesis topic. And it is also an honor to present in front of seniors like Revati ma'am and Rama ma'am and my dear colleague Josephine ma'am. So without much delay, I'll just go into the topic. There are no financial disclosures. The scope of this talk would be under the following headings. First, briefly the background. What are the types of KPro? What are the indications? How do you do the pre-op workup? The surgical procedure, I'll demonstrate it to a small video. What is the routine post-op care? What are the complications and how do you manage them? And what are the future trends in this procedure? So if you see into the background, Quincy was the first to do KPro. Actually, not first to do the KPro, but actually it was the first attempt on doing a keratoplasty. The first attempt on doing a keratoplasty was not by using a human tissue or any other tissue or biological tissue, but he tried to do it with help of a glass, which he put in on a metal and then tried to implant it on the sclera. So the actual concept of corneal transplantation started off with a KPro, and then slowly the trend of keratoplasty picked up from then. So the credit of KPro should be given to Quincy. And in the modern medicine, I think KPro, as all of us know, is used as a last resort for curing corneal blindness when the regular corneal transplants no longer survive and fail despite our best efforts. So in modern medicine, I think Professor Strampelli in 1963 started the osteoodontokeratoprosthesis, and that was later modified by Falcinelli. And I think in 1992, Professor Dolman, who introduced the Boston KPro, was the first to get its FDA approval. And the same is produced in India through Orolab and also known as the Oro KPro. I think the most commonly performed keratoprosthetic surgery is the Boston KPro with over 15,000 implants so far. And also this number gets added by 1,000 or so every year. So now this is the most, Boston KPro is the most commonly performed keratoprosthetic procedure worldwide with decent outcomes and good visual potential. So when it comes to the types of KPro, you broadly divide it into two types. So one is type 1, where you have a very good lid function, a wet surface. You do it as a single staged procedure. Whereas type 2, you have a dry surface. The surface is keratinized. There you want to do it as a double staged procedures. So when it comes to the composition of a KPro, it has two components. One is the optical cylinder or plate. Then you have the skirting or the anchoring material. So in this, again, we have three kinds of things. One is the biocompatible KPro. That is the Boston KPro, where we use the corneal graft as the skirt, and we have a PMMA optic in both the Boston type 1 and type 2 KPros. Then you have the bio-integrated KPro, where you use a Dacron mesh instead of the corneal graft. And also the optic is again made up of PMMA. And the Pintushi KPro is the example of this bio-integrated KPro. So this is mostly done by, in India, I think number of these surgeries were done by Dr. Muscati in Mumbai. Next, you have the biological type of the KPro, that is where you use the tooth or the bone of the patient and put a drill into it and put the optical cylinder. So this autologous biological tissue is also called as the OOKP or the modified OOKP. And Sankar Nethralaya Chennai, I think they have been doing a lot of these OOKP cases in our country. So when it comes to indication, type 1, the most common indications are multiple failed grafts, aniridia, and in herpetic keratitis, where you have multiple scars and repeated surgeries fail, silicone oil filled eyes. These are all the cases that you also have a good prognosis. When it comes to pediatric corneal conditions and chemical injuries, type 1 also has a role, but the prognosis is guarded. Whereas in type 2, that is the dry surface, you have the Steven-Johnson syndrome, OCP, MMP, severe chemical injuries, and a severely keratinized surface. So depending upon the indication, you can choose the type of KPro that you want to use. But I think my today's talk, I'll broadly cover and concentrate more on type 1, which we use more commonly in our practice. So type 1 is the Oro KPro that is available in India. So this is the first picture you can see here. And type 2 is a modification of the same with a longer optical stem. So this is called as the LVP KPro, again produced in Orolab in India. So I think these two are the common Boston KPros that we are mostly using in India. Oro KPro and the modification of it into a type 2 called as the LVP KPro. So what are the things that we have to look for before we take the patient for surgery? So you have to look at the visual potential, whether the patient has an accurate perception of light and projection of rays, and also try to look for the digital intraocular pressure, try to see if the eye is already hard and has sufficient damage from glaucoma, evaluate the blink mechanism, ocular surface, how is the tear film and everything. Ideally, for a type 1 case, you should have a streamers of about 10. Also try to do an ultrasound B scan and look for optic nerve cupping. If there is a significant cupping of more than 0.5 millimeter, it should be evident on B scan. Also try to look at the macular conditions if possible. Look at the lens status because that will guide you to the determining the power in the optical cylinder that we are going to place. Next, you have to do an A scan. Again, this is useful to calculate the optical cylinder power, and also look for any chronic signs of inflammation. Treat that first. Make sure that the eye is quiet and suitable to do a keratoprosthetic surgery. So if you see this picture shows how the type 1 Boston KPro is assembled. So if you see first, you plate the optical cylinder that has a front plate, and this is the optical cylinder which has these grooves in which the other assembly parts go and sit in. The second part is the cornea, that is the skirt we use. Then third part is the back plate. And finally, the assembly is locked with a titanium ring. So the four parts that are used that you see here is the front plate with the optical cylinder that has the grooves for the other parts to fit in. Then you have the cornea that surrounds this like a skirt, and then the back plate with fenestrations, and finally the titanium ring. And the refractive power selection in pseudophakic eyes, we usually retain the IOL, use a pseudophakic KPro that comes with a 45 diopter power. In phakic eyes, we remove the lens and try to implant an aphakic KPro. And in aphakic eyes, we do core vitrectomy and implant a aphakic KPro again. So depending upon the axial length, this is an algorithm in which we try to get the power of the optical cylinder in this KPro. So now let's look at the surgical procedure. So these are the components that we get. So this is the back plate, titanium ring, the central trephine for 3 millimeters, and the locking. So that's the titanium ring that you see here, and that's the back plate. And that's the optical cylinder with the front plate. So these are the steps that you can now see in the video. So now coming to the donor preparation. So as the back plate is usually 8 millimeters, we try to take an 8.5 or 9 millimeter trephine, mark the center. That's the central 3 millimeter trephine. Make sure that this is central. Once that is done, you can see that hole. So this is the animation of the same thing that you can see here. Now, place the optical cylinder with the front plate and place the trephined corneal tissue over it. it's ideal to use a fresh tissue as far as possible. So that's the front plate with the optical cylinder, and there you just push it. Next, you put the fenestrated back plate. Make sure that it properly sits into the grooves that are there in the KPro. And finally, the titanium ring. So once this ring is locked, you get a click sound that indicates that the assembly is ready for use. So this is how the KPro assembly looks after its completion. So in the interest of the time, I'll just forward the definition part. It's like any other regular PK. And once that is done, now you can see the central clear optical part with the corneal rim. And the suturing is again similar to any keratoplasty. And by the end of surgery, this is how it looks. So one modification that we have done to this technique is, so instead of burying all the sutures, we tend to keep 4 sutures in 4 quadrant exposed so that you attract vascularization in these cases. So that will help in early fusion. And also whenever the BCL falls off, it acts like an irritant and prompts the patients to come back for seeking care. And now this is the newer Lucia design where there is no locking ring now. The backplate itself acts like a locking ring, and the design is also petalloid, giving it a more cosmetic appeal when compared to the other thing that we have been using previously. So post-op, we usually put the patient on prednisolone 2-hourly and then slowly taper them. And for 3 months, we put them on soft steroids BD. And antibiotics, we can use moxifloxacin, chloramphenicol, or any other antibiotic. But in these cases, I think we don't use preservative-free antibiotics, but go with the antibiotics that have BAK, because BAK itself also has antifungal properties that is more relevant to the population that we're treating in our scenario. Anti-glaucoma agents are also a must, like timolol and brimonidine combination is what we give routinely. And pulsed antifungal therapy also we try to give once in 3 months or 6 months. BCL is examined every month, a betadine cleaning is done, and oral antibiotics are given usually for 1 week or 10 days post-op, and injection dexamethasone is given 2 to 4 cc daily for the initial 3 days. So the most important thing that you have to see in post-op is changes in refraction. So whenever there is an hyperopic shift in this patient, you have to suspect an early leak and look for that using a Seidels. And whenever there is a myopic shift, try to see if there is an increased IOP and see how you can manage that condition. So the most common complications that we have post KPro are the retroprosthetic membranes, and in long term, the extrusions. The complications can broadly be divided into 2. That's the tissue necrosis and the postoperative uveitis. So corneal melt, aqueous leak, end of glaucoma, extrusion of the device are all related to the necrotic part. RPMs, vitritis, macular edema, and retinal detachment, and finally going into phthisis can be because of the uveitic complications. So sterile melts, these are the melts that you commonly see in the junction of the optic and the corneal skirt. And these, in our experience, in some of the cases, we could treat it with the help of doxycycline and cross-linking as a combination therapy. So this is the progressive photos that you can see after therapy with the regular treatment on. So post-op survival, so far we have performed 63 KPros in the past 6 to 7 years. And the average survival rate is 2 to 3 years. Some grafts, however, survive even longer, but the average is 2 to 3. Most of them would again require a regrafting or re-KPro, depending upon the complication and the advancement in that particular complications. So the top 5 tips given by the master himself, Dolman, is to keep the pressure down. Prophylactic anti-glaucoma, he tends to use Dimox for lifetime, sometimes OD or even BID. And those with pre-existing glaucoma should have a shunt as a combination surgery. And those with chemical burns should have an infusion of biologicals right away to prevent long-term complications. And prophylactic antibiotics, he feels that it's better to have BAK for its antifungal properties rather than the preservative-free properties. And glaucoma being the most common complications that we see post-op, I think digital palpation is what all of us do routinely. But I think in future, we have some things like this telemetric IOP implantable sensors in the sulcus. If they can be implanted along with the KPro so that you know what is the exact pressure that's going inside the eye, but this is still far off from clinical use. So the lessons learned from KPro is glaucoma is a very common sequel, and we prefer to use the smaller back plate because it creates lesser crowding, and always use antibiotics with BAK, and follow-up is very close follow-up is very important. Leaks to be avoided. 4 to 3 knots, we keep it exposed on the conjunctival side. That's the reason I have already told you. Use a fresh tissue with an accurate central punch. Oro KPro, in our experience, I think is definitely a viable option as a last resort in cases where graft survival is, graft failure is inevitable. I think the LVP group have also compared the Oro KPro outcomes with the regular Boston KPro in the ophthalmology journal, and they felt both the outcomes are comparable. Now coming briefly about the other KPros. So this is the OO KPro that I mentioned that the SN group does a lot. So this is the transparent optic, and the skirt of the material is usually a tooth, and they drill a hole into this tooth, and in the intralamellar stroma, then you cover it with skin so that it gets fused well, and then they implant it into the eye. This is how post-op looks. So their survival rate is 70%, and over 10 years, this also comes down to 30%. Next, commonly used KPro, apart from these two, are the Alpha Core, that is by Professor Chirilla. Here he uses a plate optic. This is again a two-stage procedure where he lifts the cornea as a stromal pocket, keeps this Alpha Core with the optic, and then closes it, allow it to heal, and then creates this central opening. Through this central part where the optic is already there, the patient regains good vision. Next is the biosynthetic cornea. Again, this is the anterior lamellar part where the endothelium of the patient is still retained. And these are the few things. Professor Perforation, he was the first to perform this in Sweden using the recombinant human collagen 3 material. So I think that finishes the talk. I would be happy to take any questions from the expert panel.
Thank you, Dr. Udhuraju, for that excellent talk. You've given a wonderful overview of keratoprosthesis, right from the history to the surgical intricacies to the complications. Thank you so much. Very comprehensive talk indeed. So I now invite our panelists for their expert comments. I'll start with Dr. Rajaraman ma'am, Dr. Revati.
Thank you. And as usual, Madhu, it's a very, excellent presentation with all the newer things also to teach the students. And our experience is only limited to the RO KPro to the maximum extent, and the rest of the KPros we never use. I have no experience. And in case of RO KPro, yes, whatever, Madhu has covered everything extensively. Only thing, like when we advise, one point what we have to keep in mind, this is going to be the last resort for the patient. And when there is a possibility of doing keratoplasty, even another nth number of keratoplasty, and still if the patient is having that chance, better to go for it. Because I personally have an experience on some patient who came for the 8th graft. He underwent several grafts in several places. For the 8th time graft, he came and he was insisting, you do this. I have faith. So you do it, just do, we'll see. So with a lot of apprehension, I did the thing, and fortunately, still almost now around 20 years, he is still holding on with that. Somehow it clicked. So we can't say. So if there is a chance for a graft, still go for a graft. But if it is a one-night patient and this is maybe the only chance for giving some useful vision, yes, this must be the option, and you can have to give this to the patient. Yes, that we have to keep in mind. And the preoperative workup and postoperative care are the most important thing. KPro doing is maybe very simple, and if you are well-versed keratoplasty surgeon, you can easily do it. But as Madhu pointed out, small nuances in doing during surgery and in the postoperative care is very, very important. And I would like to hear Rama's views about the other KPros, because I think they have more experience with other KPros also.
Yeah. Keratoplastics, I totally agree with you, ma'am. As long as the patient has a chance, sometimes even after failed KPro, we can also do a keratoplasty.
Yes.
So there is never no to a keratoplasty, but as you rightly pointed out, this will be the last resort, especially in one-night patient, taking into the field of view, constriction and everything. This is the last option we can give them. Thank you, madam.
Dr. Uduraju, what is the cause for this KPros failing? You said that they would last a few years and then they would fail.
Madam?
What is the number one cause for these KPros to fail after a few years?
Yeah, usually it happens like 2 to 3 years afterwards. They tend sometimes extrude, or sometimes they can be RPMs that are very thick, or sometimes they can have infections that we need to remove them. Multiple reasons are there. But sometimes they survive till 5-6 years also. The average is 2 to 3.
And then how many times do you put in a KPro, like in your series?
I think in our 60 odd cases, I think so far maybe 4 of them I did a re-KPro again. Few cases I could not do because they went into phthisis because of bad infections or other complications.
Okay.
Sometimes, as madam rightly pointed out, you can also try a keratoplasty and then give it a chance once again.
Okay. Thank you. Dr. Rama Rajagopal, I now invite your perspectives on this topic.
So that was a very excellent presentation, and I think all agree that if there is a possibility of doing penetrating keratoplasty, then all of us would go for it. But there are these patients with end-stage diseases where you're really left with no other choice. The one suggestion that I would have is that when you're doing these repeat keratoplasties, I always prefer to understand what is the prognosis in terms of how the disc status is and how the macular status is, because that can be one deciding factor on whether a patient will benefit with keratoprosthesis or not, other than whatever you have highlighted. Because I find that repeated grafts, the risk of sometimes the increase in pressure continues to happen, and these patients end up with pale disc, and these patients may not be ideal candidates for keratoprosthesis as well. And over the last year, I personally don't do keratoprosthesis, but I know in our institute over the last 20 years, Professor Dr. Falcinelli introduced us to the OKP procedure, and we have done a considerable number of procedures. But I think, and the Boston and OroKPro as well, I think there are reasonably clear zones on which procedure to choose for which patients in most instances. But what is most important is, I think, understanding that these patients require a very close monitoring. They have to be clearly spoken to about the importance of postoperative medications, because sometimes we find patients don't use them, they don't come to change the contact lenses, and that is when they develop infection and we lose these eyes to endophthalmitis. Endophthalmitis still seems to be a risk factor, but I think these are all end-stage diseases where you're left with no other choices. A good counseling, a good follow-up may possibly help us to retain whichever form of processes for a fairly longer period of time. I have a question to Dr. Madhu. You said about the men, right? Do you see any particular group of patients from indications as having increased risk of MED in terms of the primary disease for which we are doing the procedure?
Ma'am, can you please repeat the question?
No, you did say that a lot of them can have, some of them do have MELs. We also see MELs. So the question is, from the indication point of view, are there a set of patients who are more predisposed to have these sterile MELs as compared to others?
We
Like,
did not,
do you think? if a patient, yeah.
Yeah, I think
No, if you have a,
I
yeah, please go
understood.
ahead.
Sterile melts you're asking, no, madam?
Yes,
Yeah,
yes,
yeah,
yes.
sterile melts is usually this is more like an ocular surface problem. So, like if you are not choosing the right patients, like if we are going on borderline patients with less than 10 mm streamers with a compromised ocular surface, or they're not using the drops properly, or these are the cases that are more prone to surface melts that are sterile. In our
Right.
experience, that has been what we have seen.
Yeah, I think that's what we have also seen.
Yeah, and sometimes if there is an irregular junction between the optic and there, then you have a leak from there. Those are the areas that also start the melt from that edge and it goes out.
Okay, thank you.
Also had punctal occlusion, punctal cautery or whatever, and also two small torsorrhaphies on both sides to
Yes.
reduce the ocular surface. Those things also can help in
maintaining it.
making the
Yes.
ocular surface better.
Yes, ma'am.
Dr. Josephine, I invite you to the discussion and invite your comment.
Thank you, Doctor. So personally, I don't have any experience in doing keratoprosthesis, but I've heard from Dr. Revati ma'am and Dr. Anita Venugopal from Delhi. So they've done a good number of or a KPro. And one of the most commonest problems or complications that they see is the extrusion. And I also did have a very brief observation period in Mass INDR with Dr. James Chodosh. So he also does a lot of KPro. So what he advises is post-operatively is these patients need a lot of chair time, lot of counseling, and during the post-operative follow-ups, as just now Dr. Madhu and Dr. Ramaman were discussing, looking for the ocular surface and the earliest site of leak. So that is where the melt starts. So you stay in and see, and also checking for their intraocular pressures is very difficult in these patients, and he advised like check for the digital pressures and make sure that the optic disc is always evaluated in these patients, and maintaining the ocular surface at every visit, making sure like things like punctal plugs, startherapy, and whether the bandage contact lens is well in place. All those things will help improve the success of keratoprosthesis. I think this is what I wanted to add with little bit of experiences that I got from him. Thank you.
Dr. Madhu, in your case series, what was the most commonest indication of a KPro in your series? You know,
ours was multiple failed grafts, ma'am. More than 60% were multiple failed grafts. Few cases of aphakia or a disorganized anterior segment, and some chemical injuries that had good surface wetting. These were the common indications that we.
okay. And how expensive is this Kerat? Is it a very expensive proposition for the patient?
No, ma'am. Actually, the KPro, you can get it for 7,000 rupees.
Okay.
And in our government scheme, we had got it included, so that patients who cannot afford also can get it done through the government health scheme.
And once the patient has a KPro in place, how often do you call them for follow-up? You know, when like
initial 6 months, it's every 1 month, ma'am. Then we slowly do it as 2 months, 3 months. 3 months is mandatory.
Okay. Anything else that the panelists would like to add to this discussion? Any experience with some other alternative KPros or any advantages of the other KPros, Dr. Rajaraman, ma'am?
As
Or
I
is this
pointed
the
out,
best that
I
we
have
have?
very little experience or observation, but Dr. Madhu, I was observing Dr. Dolman. So he used to tell at that time, somehow they almost overcome the problem of extrusion. But for them, the main problem is glaucoma.
Glaucoma, yes.
At that time, he was along with, I think, if I remember correctly, with Ahmed or somebody. So they were working on, and he used to tell invariably there should be an anti-glaucoma surgery.
That's the 5
some
points
kind
I
of
showed you.
Yeah.
That he
So
told.
he want to, I mean, he said glaucoma is my maximum
Yeah.
this thing, the reason for the main reason for the failure or whatever he used to
Yes.
tell.
Thank you so much. So a big thank you to all the panelists for their very expert comments and for the wealth of information that they shared, in the discussion. Thanks also to all the speakers who've presented such excellent talks, very comprehensive and very detailed, especially very well illustrated with pictures and videos. So a very, very big thank you to our panelists and the speakers. And also thanks to the audience that has been with us this morning. We thank you for your presence. And if there are no more comments, then with that, I think we come to the end of this webinar. And I again invite you, like I mentioned, GuruSangam is an ongoing series of lectures. So next Saturday evening and then Sunday morning and Sunday evening, we have more lectures. So I invite you to be a part of those episodes also. And with that, we come to the end of this episode. Wish you a very, very happy Sunday. Thank you so much.
Thank you. Really enjoyed being part of this. Thanks a lot.
Thank you.